A discussion on muscle diseases isn't complete without a discussion on limb girdle muscular dystrophy. So let me invite our speaker for the next talk, Dr. Vishnu. Sir is Dr. Vishnu. Dr. Vishnu is Assistant Professor at Department of Neurology at AIIMS, New Delhi. He is currently an ICGNMD MRC Fellow, has numerous publications and extramural projects in his credit. Currently selected for World Stroke Organization Future Leaders Program 2020-2022, has also established a GPS consortium across India and an AIIMS primary CNS vasculitis registry. His main areas of interest being neuromuscular disorders, stroke, and CNS vasculitis. So let me invite Dr. Vishnu for sharing his experience and his knowledge on limb girdle muscular dystrophy with us. Over to you, sir.
Thank you, Priyanka. Can I share my screen?
Yes, sir.
Hope I'm visible, right? Slide
Yes.
15?
Yes, sir.
Okay. Thank you, Professor Sharma, sir. I mean, he has clearly made my job much easier. Because I will not be touching any of the muscle biopsies because he has already covered most of the part. So I'll be discussing about limb girdle muscular dystrophies. And the limb girdle muscular dystrophy is a huge topic. I mean, in half an hour, it's to finish limb girdle muscular dystrophy in half an hour is not possible. So I will not be discussing every aspects of limb girdle muscular dystrophy. Sorry, my slides. Yeah. So I have nothing to disclose, but I would say that I'm thankful to Professor Volker Straub of Newcastle University, who is in charge of the limb girdle muscular dystrophy part of our fellowship program. So I have been listening to his lectures, papers, reading his papers. So a lot of things of this talk has been influenced by him, and also, not influenced, maybe plagiarized from his papers and lectures. And also thanks to ICGNMD for the opportunity. So my objective is to talk on the new definition of limb girdle muscular dystrophy. And some of you may be thinking, when you say about new definition, was there an old definition or not? So I don't know how many of you are aware that there was a definition of limb girdle muscular dystrophy. If not, yes, it was. There was a definition. An update on the recent classification. All of you would have known about the old classification of that. Dr. Sharma also was mentioning LGMD1 and LGMD2, which everyone knows. So, I mean, it's the flavor of the day to change, to put new classifications. If ILE and movement disorders can put up every 2 years, so the neuromuscular group also decided that we will also come up with a classification. But jokes apart, they have done it after 25 years. So after a lot of recent advances. So I think they are entitled to do a new recent classification. There are issues with that. And I will these are the two main objectives. If these two are covered, then I will be happy in half an hour. I'll be talking a little bit of neuromuscular imaging, primarily because we are trying to establish a neuromuscular imaging protocol with Professor Ajay Garg for our AIIMS Comprehensive Neuromuscular Disorder Center. So we are I've been reading about neuromuscular imaging. I'll show you some basics of neuromuscular imaging. If time permits, we'll summarize some of the common LGMDs, but it's unlikely that we'll get time. And I'll have one slide on the ICGNMD, so that the audience also can benefit out of that project. So if you want to read about limb girdle muscular dystrophies, these are the giants who have done work on it. It's in Kadilkar sir's book, and the paper on practical neurology is a brilliant overview of it. And everybody should want to know about limb girdle muscular dystrophies or any other of neuromuscular disorders should read his book. It's a comprehensive overview, and the latest one, all the updates are there in the 2019 Continuum Limb Girdle Muscular Dystrophies. I think for exam going residents, this should be good enough. So what is limb girdle weakness? When you have limb girdle weakness, when any approach to muscle disease, always pattern recognition is the crux of the matter. So limb girdle weakness is the most common part of a pattern recognition that we have when you have a differential diagnosis. Where does this limb girdle muscular dystrophy word come from? It just came in the landmark paper in Brain in 1954 by John Walton, which later on became Lord Walton and Nattrass at the Newcastle University. They first described this paper, the limb girdle muscular dystrophy in this paper, which is a 68-page paper in Brain at that time. In that, they said that we suggest that they should be called limb girdle muscular dystrophy, a group of diseases which are distinct from Duchenne and Becker muscular dystrophy. They point out 4 cardinal features. Onset usually late in the first, second, or third decade, but sometimes in the middle age. Commencement of muscular weakness in either the shoulder or pelvic girdle. Transmission usually via an autosomal recessive gene. A relatively slow course which nevertheless leads to severe disablement before death or the normal age. So at that time, autosomal dominant thing was not known, relatively well described, but it was also criticized because they told this is also a wastebasket diagnosis. You're trying to put all known DMD or BMD into one particular group, like at one time HSP or before genetics, mitochondrial diseases were considered. So two things I want to say about is a few things about before going to LGMD proper is most common form of an inherited limb-girdle pattern of muscular dystrophy is still Duchenne or Becker muscular dystrophy. And every male with a limb-girdle weakness should first be tested for a dystrophinopathy. We don't recognize it, we don't miss it much because even if you write LGMD to a muscle biopsy and send it to pathologist, they will check for dystrophin. So that's why we are not missing that much, at least in that aspect. Female plus limb-girdle weakness and elevated serum CK, always consider a manifesting DMD or BMD carrier. So because many LGMDs are rarer than the manifesting carrier of DMD or BMD. So this diagram, I think different variation of this diagram that Dr. Sharma has already shown. For all the exam going residents, I would still use, you draw this diagram, at least by hand drawn diagram and keep, because even if you learn if you just learn about all the genes and proteins by heart, it will not get into an understanding of this. When you know that where is the protein exactly lying on in the muscle structure, from the extracellular matrix proteins to the dystroglycans, all the sarcoglycans lying on the sarcolemma, the dysferlin, anactomin, the myotillin, kelithianine, all these things. When you get into that, it's easy to understand the pathophysiology and understand the importance of each genetic mutation causing where the protein are final common pathway where it's going to affect. So I'm not going to the details of the pathophysiology, but at least this is a rough overview of the pathophysiology. We can affect the dystrophin glycoprotein complex, nuclear function, sarcomere, glycosylation, trafficking, and signal transduction. So coming to the old definitions, the old definition was pretty easy. It's a postnatal onset of progressive muscle disease, which starts in and predominantly affects the pelvic or shoulder girdle muscles. So this doesn't look like a definition. That's why many people didn't know that there was a formal definition was there. So ENMC 1995 classified them into LGMD 1 and 2. A letter was added, like A, B, C, like A to Z for the order of discovery of the chromosomal locus. So we had up to 1 to H. Sometimes you might see 1I also for the autosomal dominant calpainopathy. It depends upon, because that came at around the time when the classification was changed. Some books you won't see. So LGMD2, it came to A to Z. So we know that 90% are LGMD2, the recessive ones, 10% are autosomal dominant. The recessive ones are more severe, the more highly CK elevated. And you see the CK levels. So the highest levels are seen in LGMD2 and LGMDL, anactominopathies and the dysferlinopathies, then followed by sarcoglycanopathies. Then you see the FKRP and all the dystroglycanopathies. Then comes the calpainopathies and others. So this is one way of differentiating between LGMD. When you clinically see, when you have a CK levels, when it's very high, it is very less likely chance that it will be LGMD1. It's most likely a recessive LGMD. So what is the problem with the previous classification? One, the major problem is, even though there are other problems listed here, all these others could have been sorted out. But the major problem was that we ran out of alphabets. We went up to Z. Now the next time, OMIM will have to classify it as 2AA, that is AA. So nobody wanted to do that. So that then there was other problem with multiple diseases having the same thing and the same autosomal dominant and recessive. Some things are entirely different, like myofibrommyopathies are classifying into LGMD. So a lot of issues were there. So from that, they wanted a new classification. Now this looks like a definition, and usually a definition should be a complicated thing, right? So now it came a complicated definition. It's not very complicated, but let's run through it. So LGMD is a genetically inherited condition that primarily affects skeletal muscle, leading to progressive, predominantly proximal muscle weakness at presentation caused by a loss of muscle fibers. To be considered a form of LGMD, the condition must be described in at least 2 unrelated families, with affected individuals achieving independent walking, must have an elevated serum creatine kinase activity at any point of life, must demonstrate degenerative changes on muscle imaging over the course of the disease, and have dystrophic changes on muscle histology, ultimately leading to end-stage pathology for the most affected muscles. So you don't have to by heart this, but you should know what's the keywords, what is the importance of it. Let's break it up. One is a genetic cause of disease. You don't want, because limb-girdle pattern is the most common for usually in the muscle weakness. So you don't want to have acquired conditions being labeled as limb-girdle muscular dystrophy. So that one. Then progressively predominant proximal muscle weakness, obviously limb girdle, you have to be a proximal muscle weakness. Condition which permanently affects the skeletal muscle, yes, you don't want a spinal muscular atrophy which having a limb girdle pattern to be labeled as a limb girdle muscular dystrophy. Achievement of independent walking at some point, you don't want a congenital muscular dystrophy to be labeled as LGMD, so you want to have a patient who have achieved independent walking, then deteriorating. Weakness is caused by loss of muscle fibers, of course, no anterior hornsel or nerve fibers to be involved. Elevated serum kinase, it need not be very in thousands, at least some amount of muscle destruction will cause serum kinase level to be elevated. Degenerative changes in muscle imaging and muscle biopsy, and it has to be in two different family systems. So to have a causality of a gene, one single gene affected, you have to be a causality, at least two different families should have the same gene. So this was the old classification. How did the classification change after the new definition? So let's see. So what happened is the first three got shot down. I will tell you why. Then came the desminopathy game. You see a desminopathy has got a recessive component also. That will also go. Before that, 1H, nobody knew what it was. When it was, somebody was very enthusiastic in putting it up the ring. It was a false linkage, that gone. Then R gone, the desminopathy gone. Then V to Y gone. Easy to remember. My name is Vishnu VY. So you could check in V to Y, all four are gone. So only thing was among that, we'll go look at why they were removed. LGMD 1A, it was primarily a myofibrillar myopathy in a distal weakness. It was not a limb girdle pattern weakness. That's why it was removed. 1B is primarily a emery-Rufus muscular dystrophy, so it was classified as a separate one. 1C is the primary characteristics is a rippling muscle disease, so that was also removed. 1E is the primary false linkage, and all desminopathies have been classified as a myofibrillar myopathies, so both recessive and both of them are removed. 1H anyway, it is a false linkage. 2V is it's a clinically different entity of Pompe's disease, so it's already well-established disease. They don't want to put it into LGMD, so that was also removed. Rest of them were removed because they were reported in one family. Of its 2X, they came back. So if it's removed, if multiple families are later on discovered, then you can come back. It's like getting out of a cricket team and then performing well and coming back to the team. So all those these removed, because there is only report in one family. When more families are reported, they will come back. So this is the current classification. 2018 or 2017 was the NMC meeting published in 2018. So we have a dominant and inheritance, D and R, in the order of discovery of the number. The D1 the order of discovery of and the protein related. So what we call them as calpainopathy or dyspharinopathy. Just put the protein into it. That's easy to one. And they put that, they later on said that if other than DMD or BMD, if a letter X is denoted, if in future we discover an LGMD, an X linked, so they're labeling it as LGMDX. If it is a very clinically inherited LGMD, which gene cannot be discovered or cannot be found out, they may label it as LGMD unclassified. There's no one in that group till now. In the LGMD, two new one has come. That is the dominant calpain-related, autosomal dominant calpainopathy, D4, and the collagen 6 related. The Bethlehem myopathy is a dominant in D5, and the recessive one is also there. Is R22. And there are three more: the laminin, POMG1, and BVS, which is one which is removed and then came back. In sarcoglycanopathies, previously, if you look at the old classification of sarcoglycanopathy from 2C to F, there was some, the gamma sarcoglycanopathy was the one which was first found out. That's why first 2C became gamma. So when a nomenclature is usually alpha, beta, gamma, delta. Here it starts with gamma, then alpha, beta, delta. So there's some discrepancy was there at that point. So this time they corrected it. They started R3 with alpha, R4 beta. Now it is in the correct form, alpha, beta, gamma, delta. So only thing is only for the resonance, you do not assume that the 2C was the initial one. The gamma sarcoglycanopathy is now R5. It's not R3. So that's a slight change. That's just know it. These are the new LGMDs which I told you. Now we'll look at a little bit of neuromuscular imaging. This is the book by Mike D. Wages and Vischer. It's an excellent book. This is the book I read for knowing some basics of neuromuscular imaging. So all the images which I'm going to show is from this book. So I'll show you some of us from the limb girdle muscular dystrophies. Predominantly, we image the lower limb. As can image the upper limb also. But imaging mainly most of the findings you can get from there. I will show you some of the images of the lower limb. So we can see in the pelvic level. So there are three levels. You get the pelvic level, then the thigh level, and the lower leg level. In the pelvic level, you need to identify three major muscles: the gluteus maximus, the medius, and the minimus, which you should be able to see here. Then comes the thigh level. So you can see the vastus intermedius, vastus lateralis, the rectus femoris, the sartorius, the adductor longus, the gracilis, the adductor brevis, which is can you see here. Then you got the adductor magnus, and this is the gluteus, the lower end of gluteus. Then the biceps longus, which will come here in the next cut. Why I'm showing you this is, if you want to know a pathology in the muscle MRI, you should know the normal muscle where it is. Then only you will be able to find out. So when you come down, so you can see the biceps longus is come here, the semitendinosus and semimembranosus, the big chunk of muscle is the adductor magnus, the gracilis and the sartorius. This is the adductor longus. Again, the vastus intermedialis, you can see here intermedius, the rectus femoris and the vastus lateralis. Again, this cut is the one which is usually used for most of the pathology. To see here is the cut which you can use. Next cut is little more, we can use most of the things. So you can see the biceps, shorted of biceps, the biceps longus, semitendinosus, semimembranosus, adductor magnus, gracilis, sartorius, and all the muscles can be seen in this scene. So, I mean, in lower cut, you can see the same thing down. Now coming to the calf, again, you have got the tibia and the fibula. The anterior part, you've got the tibialis anterior, essentially the longus and the peroneus longus. You can see the soleus and the gastrocnemius lateral and medius. Again, now we can see the whole soleus part here, the medial part of gastrocnemius and the lateral part of gastrocnemius, medial and gastrocnemius, the tibialis posterior, the tibialis anterior, and the other muscles in the anterior muscles. So again, this can see the same thing. You can see the soleus and the gastrocnemius. So this is a little bit in the lower cut. So what I do is I have some 10 minutes more, so I will not go into details of each one. So what I'll do is, so for example, this one, just don't forget, I mean, this is, it's not the thing that it is LGMD3 is a rare variant of an autosomal dominant LGMD, but look at that. See, in this particular thing, adductor longus and rectus femoris are spared. So we can see the sparing of the rectus femoris and adductor longus even in the end stage, when everything else is affected, these two muscles are spared. It gives a good enough clinical clue to this one. So, for example, we go to the Bethlehem myopathy. So this is the classical appearance which we see is called as concentric involvement of the rimming of the vastus lateralis and the high signal intensity in the rectus femoris. You can use in the pictorial representation. People diagnose Bethlehem myopathy just based on MRI. If you can see the MRI muscle and say that this is Bethlehem myopathy, there is no differential for that. So you can see the classical feature in the Bethlehem myopathy. So somebody having a proximal contracture and the skin changes and the keloids and the distal hyperlaxity of the joints with this MRI picture is, unless otherwise proved, it is Bethlehem myopathy. The much more, you can see, this is, some people describe it as a white, that Siberian tiger with the stripes appearance. You can see it in Bethlehem. So we'll not go into that. Calpain, most of you, I don't think most of the things you should be knowing this. I was told about the lobulated fibers in NAD stains and eosinophilic infiltrates. I'm particularly attached to this lobulated fibers because this was asked to my DM exam when I was when my CA exam. So I was asked what are the differentials of lobulated fibers. Okay, what are the other conditions where just I told it's not very specific. It can be seen in Bethlehem, dystrophinopathy, FSHD, some telethinopathies and all. Eosinophilic infiltrates can be seen in other conditions. So same thing with the calpain. Calpain also, if you do a muscle MRI, you can see progressively how the gluteus maximus is atrophied, how the anterior compartment is spared in the thigh and the posterior compartment is severely affected. And look at the lower leg, the medial part of the gastrocnemius, the lateral part is spared, the medial part at both sides and the soleus. It is very characteristics you seen in calpainopathy. So this is so characteristically you can see here the medial part and the lateral part is spared. This will be a clinically good clue to the muscle diagnosis. And for example, dysferlinopathy and anectominopathy can mimic something like dysferlinopathy. Both can present with limb girdle weakness, the distal weakness, like Miyoshi variant can present. The same thing can occur in anectominopathy. Anectominopathy has more of an asymmetry. Both muscle biopsies can have amyloid depositions. The inflammatory changes in dysferlinopathy, vasculitic-like presentation can be seen in anectominopathy. So we'll not all the signs, the named signs and all. If you learn, we'll see some of this in the quiz tomorrow, but I'm not going to that. So muscle MRI dysferlinopathy. Dysferlinopathy is also, again, usually you can see normally in the posterior compartment in the thigh and in the calf. Sometimes you can see in the anterior compartment also, but it's predominantly in the posterior compartment in the calf. It is purely affected. The major important thing about dysferlinopathy is whether it is Miyoshi or the LGMD variant. If both types, if you purely distal variant of dysferlinopathy and the proximal variant, if you take two patients and do a thigh MRI, you can see exactly the same changes, even though the patient clinically doesn't have much weakness in the proximal. So it says that it's the underlying, the genetic abnormality is the same, and the features developing are all the same. Going to this one, anectominopathy, we showed you. So anectominopathy is same thing. You can see predominantly, even though the clinically quadriceps and the biceps muscles are affected, but usually in the MRI wise, it's mostly the adductor magnus, the semimembranous, semitendinosus. They have the sparing of the rectus femoris, the short head of biceps, and the sartorius and the gracilis. So this, and in the lower leg, the anterior compartment is totally spared. The soleus and the gastrocnemius are affected. Sarcoglycanopathies, again coming to it, can mimic like a Duchenne muscular dystrophy. It can mimic like an FKRP mutation. So you see where it's a relatively, it's not very uncommon to see sarcoglycanopathies in our part of the world. In MRI, it's a very characteristic picture. There is involvement of the pelvis and the thighs mainly, but you can see this is the most part. You should look at the lower leg. Lower leg is spared. This can differentiate between both a dystrophinopathy and an FKRP. Both times the lower legs will be affected. When there is severely affection of the pelvis and the thighs, the lower legs are spared late. So you should think of when you see such an MRI, you should think of sarcoglycanopathies or the POMPs. So same thing. So LGMD, you can see the differentiating between both points. Maybe clinically they may look the same at that point of time, but the lower legs are spared. Again, going to FKRP, I'm not going to the details of that, but still see the amount of infection affecting in the FKRP, the adductor magnus, biceps femoris, semimembranosus, and semitendinosus are affected. So you may not remember the whole thing, but you can. My point is that neuromuscular imaging will help definitely as part of the clinical, as an extension of the clinical examination. Again, this severe FKRP can mimic like a dystrophinopathy or a sarcoglycanopathy. Again, if you look at this one, lower limb, lower leg affected, sarcoglycanopathy, lower legs is spared. Not going into the alpha dystroglycanopathy such more because time I want to finish it time. So these are three things which I try to say in the Girdle Muscular Dystrophy is the new definition, and which you must have known, and the new classification of the as dominant one and the recessive one, and the utility of neuromuscular imaging. So next time you have some doubt, if you don't have a genetics testing available or then not getting done immediately, or a muscle biopsy is not, you're waiting a muscle biopsy, you can do a muscle MRI and then obviously you can decide on where you want to do a muscle biopsy, or that also can help it. So one slide about ICGNMD project. So this is about an international project involving in 5 countries, including UK, Brazil, India, Turkey, South Africa, and Zambia. So we are trying to bring a trial-ready cohort of inherited neuromuscular disorders patients who will do a genetic testing, which we available done as a part of the project without any cost. So he will be doing first the tier 0 testing with focusing on, if we have to do a southern blotting on the MLP for SMA or DMD. Then we'll do a genotypic arraying. Then if it's not getting, we'll do a whole exome sequencing. If it's not there, we'll do a whole genome sequencing. So thanks to everyone, for everyone to listen to this lecture, and thanks to ICGNMD. And these are my fellows who are there, currently doing fellowship with me in this play fellowship with ICGNMD. This was with Rita Howard's Cambridge lab, and she took around us in the Cambridge. And for everyone who wants to have a tele-appointment for a neuromuscular or for genetic testing, just email us at AIIMS-PGI@gmail.com. Thank you. I think